left gastric artery, common hepatic artery, and splenic artery usually removed in D2 gastrectomy. So here the correct answer is option D, along the gastroduodenal artery. The lymph node along the gastroduodenal artery usually do not removed in D2 gastrectomy. Question number 3. What is recommended margin of resection for curative surgery in gastric cancer? Option A was 1 centimeter, option B 2 centimeter, option C 5 centimeter, option D negative margin. So here the correct answer is option D, negative margins, that means R0 resection. R0 resection ensures complete removal of the tumor with no cancer cells at the resection margin. This is a crucial factor for curative intent. Question number and 22% student only give the correct answer. Question number 4. What is adjuvant chemotherapy or chemoradiotherapy recommended? So when is adjuvant chemotherapy or chemoradiotherapy is recommended in gastric cancer? Option A was for T1A and 0 disease. Option B for T2 or higher stage and or node positive disease after surgery. And option C for metastatic disease only. And option D for early gastric cancer treated with endoscopic resection. Here the correct answer is option B, for T2 or higher stage and or node positive disease after surgery. Adjuvant therapy is used to reduce the recurrence of risk for higher stage or node positive gastric cancer after surgical resection. Here 84% students have given the correct answer. Question number 5. Which of the following is critical for supportive care in advanced gastric cancer? Option A was palliative surgery. Option B was pain management and nutritional support. Option C was hormonal replacement therapy. And option D is radiation therapy for all cases. Here the correct answer is option B, pain management and nutritional support. Supportive care focus on the symptom management, including pain relief and addressing the malnutrition is the critical care for supportive care. Here 71% students have given the correct answer. Question number 6. For patients with gastric outlet obstruction due to advanced gastric cancer, what is a commonly used palliative intervention? Option A was chemoradiation. Option B, stent placement or bypass surgery. Option C, primary growth excision with bypass surgery. Option D, targeted therapy. Here the correct answer is option B, stent placement or bypass surgery. This improves the patient's quality of their life. 83% students have given the correct answer. Question number 7. For which patients is diagnostic laparoscopy is most beneficial in gastric cancer staging? Option A was patients with T1A tumor. Option B, patients with locally advanced tumor, that means T3 or T4. Option C was patients with confirmed distant metastasis. Option D was patients with early stage node negative disease. Here the correct answer is option B, patients with locally advanced tumor, means T3 or T4, because diagnostic laparoscopy is performed due to identify the occult peritoneal metastasis in patients with advanced primary tumor. Question here, 61% students have given the correct answer. Question number 8. What is recommended surgical approach for proximal gastric cancer? Option A was subtotal gastrectomy, proximal. Option B, total gastrectomy with D2 lymphadenectomy. Option C, endoscopic mucosal resection. Option D, proximal partial gastrectomy. Here the correct answer is option B, total gastrectomy with D2 lymphadenectomy. This is the standard for proximal tumor to achieve a complete resection and adequate lymph node removal. 71% students have given the correct answer. Question number 9. What is the primary goal of neoadjuvant chemotherapy in gastric cancer? Option A was to palliate symptom. Option B, to reduce tumor size and improve the resectability. Option C, to replace surgical treatment. Option D, to treat distant metastasis exclusively. Here the correct answer is option B, to reduce the tumor size and resectability. Neoadjuvant chemotherapy aims to shrink the tumor and facilitate the complete resection and address micrometastatic disease. Nearly 95% students have given the correct answer. Question number 10. What is the preferred approach for T2N0M0 gastric cancer? Option A was neoadjuvant chemotherapy followed by surgery. Option B was surgery alone. Option C, surgery followed by adjuvant chemotherapy. Option D, chemoradiation. Here the correct answer is option A, neoadjuvant chemotherapy followed by surgery. Neoadjuvant chemotherapy is increasingly recommended for T2 and higher tumor that improves the outcome if nodal involvement is not confirmed, according to the NCCN guideline. So the nearly 34% students only have given the correct answer. Question number 11. Which of the following is a contraindication for neoadjuvant chemotherapy in gastric cancer? Option A was T3N0 disease. Option B, T1N0 disease. Option C, node positive disease. Option D, patients with HER2 positive tumor. Here the correct answer is option B, T1N0 disease, because the chance of micrometastasis is very low in T1 disease. So neoadjuvant chemotherapy is usually not necessary for this stage. 54% students have given the correct answer. Question number 12. For a patient with resectable T3N1 esophagogastric junction cancer, what is the standard treatment approach? Option A was surgery followed by adjuvant radiation. Option B, definitive chemoradiation without surgery. Option C, neoadjuvant chemoradiation followed by surgery. Option D, surgery. Here the correct answer is neoadjuvant chemoradiation followed by surgery. Neoadjuvant chemoradiation such as cross regimen, that means carboplatin and paclitaxel with radiation, that improves the survival, and it also increases the rate of R0 resection and resectability for locally advanced disease. Here 81% students have given the correct answer. Question number 13. What is the preferred surgical approach for Seward type 2 esophagogastric junction tumor? Option A, total gastrectomy with D2 lymphadenectomy. Option B was transhiatal esophagogastrectomy. Option C, Ivor-Lewis esophagectomy. Option D, subtotal gastrectomy. Here the correct answer is option C, Ivor-Lewis esophagectomy, because for two tumors, Ivor-Lewis esophagectomy, that means thoracoabdominal approach, that provides the optimal access for achieving a negative margin and also to remove the lymph nodes, that means for the lymphadenectomy. So the correct answer is C, Ivor-Lewis esophagectomy. Only 38% students have given the correct answer. Sir, that's all.
Okay, thank you, Dr. Abdul Al Maruf, for nicely moderating the poll and as well as the question designing. Covered a lot of spectrum on the gastric cancers. এখন আমরা একটু আমাদের faculty থেকে will take some comment. Professor Maruf Hossain sir, have you joined? No. Professor Ibrahim, will you make any comment on this poll?
Thank you. First, thanks to Dr. Maruf for submitting such a wonderful poll with a very pertinent and relevant question. About question 6, we focus on question 6.
Yes.
Gastric outlet obstruction due to advanced gastric neoplasm or gastric cancer. Options were the stent and bypass or primary growth restriction or bypass surgery. Is there variable the opinion among the faculties here?
Okay.
The patient has got outlet obstruction due to advanced gastric cancer. There are two options in the middle. The second option was stent and bypass, and third option was primary excision and bypass surgery. Actually, if the stent placement is not possible, then what we are going to do? So 2 and 3, they are almost almost similar answers, isn't it?
Sir, according to the guidelines, sir, They have said that if it is possible, the stent placement should be the first option. And if it is not possible, then bypass surgery can be done, sir.
Not excision.
Not excision, sir.
Because it is more than T2 probably.
Yes, sir.
Well,
So we can take comment from here, Dr. Shivendra.
Yeah, I think the issue is in the palliative surgery, we don't want to increase the morbidity. So palliative resection increases the morbidity. In metastatic setting, it is better to have a stenting that is least morbid procedure. And if it is not possible, then a palliative GEJ is much safer than doing palliative resection unless it is bleeding. Otherwise, palliative resection is usually not advisable.
Okay, thank you so much. Thank you. Any more comment, Dr. Shivendra, about this polling today?
I think students have done well. Few questions was quite tricky. So still they have done a decent job.
Okay. Then thank you. So I think that has got to be clear from your presentation. Professor M. Modi, sir, will you make any comment?
Yes, I think everything has been well covered. I don't want to make any further comment.
Okay. So we are going to our next